All right, good morning, everyone. So let's go ahead and get started. I know we're a couple minutes past 9. Um, First, I want to thank everyone for joining us today. My name is Brent McCune. I'm the Managing Director here at the Kentucky Regional Extension Center. Really excited to be able to host this event, especially being in person. We also this is a hybrid event, so we do have people that have joined us online. So that's exciting as well. Being able to do outreach across the Kentucky. Our events, a lot of times we'll start on the western side of the state and then have an event over in western Kentucky, central Kentucky, and eastern Kentucky. This really allows us, to communicate all across the Commonwealth doing this hybrid event. So thank you for joining us today for our annual conference. Let me see. Just real quickly to go over our mission, and really we're here to support our clients, our customers, providers, clinicians all across the state, making sure we're your trusted advisor around improving outcomes, improving better care, helping deliver better care, and also essentially reducing cost of healthcare. So we're here to support you. We look at all of our different services every year, trying to focus on where healthcare is going, what is beneficial to the practices and to the healthcare organizations across the state. So we really appreciate your all support, and we hope you all appreciate our support as well. Quickly to go over some of our services, and we have a model. We have grant services. So if you hear about some different grants out there, always reach out. We also reach out to participants we feel like are a good fit for the grant. So we have a lot of grant services, and then we also have our fee-for-service model. So we have our first service line is around it's a HIPAA security risk analysis. It's really important for healthcare organizations to actually make sure they're securing all of their data properly, protecting their PHI. So in case they have a breach, they have the documentation there. So we really, we work with healthcare organizations and hospitals all across the state on making sure that they can do their risk analysis. If you're having problems implementing different policies and procedures, we're there to support you with that as well. We can come in and do some project management and help secure your practice. We also have patient-centered medical home and patient-centered specialty practice, and so that's really bringing that medical home to your patients. So bringing a lot of additional services to your practice, and we have Vance Drakeford over there. He's our subject matter expert with patient-centered medical home and patient-centered specialty practice. Also, value-based payment and quality payment program support. So that's really Medicare focused. So if you're attesting to Medicare, get with one of our health IT advisors in the room. We can help you, make sure you're attesting properly, that you have all your documentation in place, that you understand the federal regulations around those programs. Quality improvement support. So whether you're doing Plan, Do, Study, Act, or Lean, or Agile, we can come in, we can help you around quality improvement. We're here to support you in those efforts, work with you in your practice, work with you on your different reports. So we'll be there to support you in that effort as well. Telehealth services. This is one of our newest service lines. We actually started developing this before the pandemic, and then the pandemic hit. So what timing? And of course, we developed telehealth services one way and completely have to revamp and go a different direction with it due to the emergency order. But we have that service available. I know our last presentation of the day will really be talking about telehealth and how to implement it long term. So we hope you enjoy that session. And then data validation is another service line. We've had EMRs in place for many, many years now. We know that we have data available out there, but is it the correct data? How are we using that data? So we have a team of experts that come in, do data validation, look at your reports, look at your workflows, look how you're collecting data within your EMR, and really help you build out that process to make it more valuable to the organization. So if you have any questions about that, please reach out. Hospital services, I know we have promoting interoperability. Christina Feathers is in the back of the room, so she's been working with a lot of hospitals across the state of Kentucky around this service line. It was formerly known as Meaningful Use. It's been around about 12 years, or 11 years, sorry. And it's really focused on Medicare, making sure that you meet certain regulations so you avoid payment penalties. We also have our HIPAA privacy and security service line doing those risk analysis for hospitals, really important, a lot of education. You'll hear from Amy daily. Amy's our subject matter expert around HIPAA privacy and security. We also have hospital quality improvement program. So if you're looking at those clinical quality measures, reach out to us, and we can always help support in that initiative as well. We have a packed full agenda today. So if you don't have the agenda in front of you, we have an app, CVent app. So if you go out to the App Store and you look for C as in Charlie, vent as in air vent, we'll say that. You can download the app, get logged in. There's a lot of cool things within the app. You can see the speaker bios, you can see the agenda, and you can also participate in a little game out there. So please join on that app if you'd like. We're also excited to have 3 guest speakers today. So we have Jessica Sass from UK Healthcare, and she's the Director of Ambulatory Population Health, and so she'll be kicking off our morning session. We also have Andrew Bledsoe. He's the Deputy Director of KHI, and so he's going to be talking about bridging the gap in really connected care. So it's really a great session as well. So if you don't know much about KHI or you have questions about KHI, they have a table set up out back. They have on CVent a booth set up there so you can reach out and get information. We also have Vitaly Buford. So she's talking about overcoming perfection. I have perfection issues. I will go on and tell you, I double check, triple check everything, and always like reading through my notes, emails, checking them 15 times before sending them. So I can't wait to be a part of that. Last, I want to say thank you to our sponsors and our exhibitors. We really appreciate their support, their partnership. We work with our exhibitors and sponsors all year round, so that's really important that we have them here, and we appreciate their support. So thank you to all of our sponsors and our exhibitors. We appreciate it. We do have an area in the back there where our exhibitors are set up. So please, during our breaks or during lunch, go back there, join them, have a conversation, see how they can help you all at the same time. So we do appreciate that. A couple housekeeping items. Restrooms. There's a single restroom back there. So if you see a line, go to the restrooms this way. There's multiple restrooms right out this door. So that's that will be helpful. So you're not at there's only one stall, I believe, there. Wi-Fi password or Wi-Fi is BHG. It's open, free to connect. And then we also have I already mentioned the CVent. So I think we are good from there. So now let's see. I'll go ahead and introduce our first 2 speakers. We have Jessica Elliott and Vance Drakeford. They're 2 subject matter experts in quality improvement. So we're excited to have them come up and talk about hardwiring, adaptability, and high reliability in healthcare. So we really appreciate them sharing their experiences and all of their expertise. So Jessica, Vance, come on up.
All right, thank you all so much for your patience. We all know now with COVID, you have to be flexible, you have to be adaptable, right? This is perfect segue into healthcare and what we've been through for the last, 18 plus months. So Brent has actually already introduced us. My name again is Jessica Elliott. I've been with the Kentucky Regional Extension Center since 2018, and I've been in healthcare for about a little over 15 years now, and I'm joined with my fellow Quality Improvement Advisor, Vance Drakeford, and he's been with the Regional Extension Center for over 8 years and in healthcare for 13 years. And so as Brent mentioned earlier, we work on a couple different service lines together around quality improvement and particularly around chronic disease management and making those connections with our practices to help improve the patient care and those delivery systems across the state of Kentucky. And again, here's just a reminder to connect for our folks who are in person today, because we do have some interactive features as a part of the CVent app. And so we are going to be doing a polling activity and getting your all's feedback and input a little bit later on in today's session. And so when we decided to try to come up with something to talk about and to present for our conference around quality improvement, we were really wanted to reflect back on, the last 18 months and all of the rapid cycles of change that practices have undergone, sometimes unwittingly, in this last year and a half, and how you all have had to be so adaptable and flexible, right, to be able to maintain and to be able to keep up with this environment. And so thinking through that lens of how do you then, capture and harness all of this innovation and turn it into sustainable, lasting change and improvement. And so that's really what we are wanting to talk about and focus on, is how to really move our population's health, how to really advance those outcomes for our patients and our fellow Kentuckians here across the state. And so that's what we're going to be touching on today. We're going to be looking at some quality improvement methodology. We're going to be diving down into, how to pick apart and tackle some of these problems and why it's important to pick apart and tackle some of these problems and issues, whether you're a small one-doc shop or whether you're, a multi-specialty, healthcare system, and why and how you can start going about that process. And we're also going to take a look at, how to really design and scale and scope those data-driven improvements. And then we're going to take a look at just some of the work that has been happening across the state with some of our practices and partners and how they are working to help close those gaps and bridge those outcomes with our patients and their families as well. So I think it's always good to level set and to start with, really defining what is quality improvement? What does it look and feel like? And so first of all, it has to be systematic. You have to have a framework. You have to have some guardrails with quality improvement. And it can be it can be lean, it can be PDSA, it can be DMAIC, it can be Six Sigma, but it has to have a framework. You also have to be continuous. Quality improvement is a journey. It is a process. It is evolving. Quality improvement is not just we fix this and we move on and we ignore it. You have to be constantly testing and moving and evolving, just like with healthcare. And as we've seen, we have to be adaptable, we have to be flexible, and we have to always be monitoring and measuring. And exactly that's what quality improvement is. We have to look at things that are measurable. We have to look at things that are tangible, that we can monitor, that we can track our performance around. And also, most importantly, the quality improvement efforts that we do, they have to be targeted. They have to be focused on a patient population. So whether that patient population pertains to a whole chronic condition like diabetes, or it pertains to an age group, or it pertains to a physician's clinic, but it has to be a targeted population that you're working with. And in healthcare, traditionally, healthcare focused, and historically really, focused more on the inspection and punishment of a quality assurance sort of paradigm. And over the last few years, over the last couple decades, we've moved into more of a quality improvement mindset. So going from one bad apple spoils the bunch to more of adopting a systems thinking and a systems approach of not so much, where that person made the error, but how did the system and the processes that we've designed lead to that error or lead to that particular failure? And so I think it's something I like to ask and work with my practices who are beginning their quality improvement journey is think about where you're at in that paradigm and in that transition. You know, what kind of behaviors, what kind of culture are you adopting within your particular organization? Do you encourage your staff to report errors? Do you have a mechanism in place for them to be able to report errors without retribution, that they can have that freedom to do so? Do you have a platform for your staff to be able to share ideas for improvement? Are they encouraged openly to think of ways to do things better or to make things safer, not only for them, but for your patients? Also, ask yourself, what kind of opportunities, what kind of learning opportunities do you create around errors? Because we are all human, right? Errors are going to happen. So how does your organization respond to those errors? So those are some of the questions that as you're starting to dig into quality improvement and where your culture is, you can kind of look and see where you're sort of at along that roadmap and that journey, and kind of help you decide, where you want to be as an organization and the goals that you want to set forward. Now, there's some main tenets to any good, successful quality improvement program. First and foremost is understanding your systems and processes, what goes in and what comes out of it. So understanding, whenever you're doing a quality improvement project or work, that you know the roadmap, that you know what are the stressors, what are the workflows, the parts and pieces, all those moving parts that go into your system or your application that you're trying to improve. And then does that actual output from those systems and processes, is that actually the desired output or outcome that you want to have? And then that's where you're going to be doing your cycles of change from. Next is keeping your patients at the center of everything that you do. That's another main tenet of that quality improvement principle. And so looking at quality improvement through a couple different patient-centered lenses. So whenever you're doing quality improvement work, asking yourself, how is this improvement work going to impact my patient safety? How is this quality improvement project or this quality improvement work going to impact, patient engagement, patient access? Also looking at how, if you're revamping or working on a process, are you using evidence-based best practices, to be able to deliver care to your patients? Talking to your patients through and whenever you're making updates to processes, are you explaining the who, what, where, when, why, and how, and giving a patient-centered delivery of communication about those needs? Are you looking at the health literacy of the materials you're developing for your patients and making sure that that's something that they can understand? So all of those things go into some of the work and some of the lenses that we can view quality improvement through to make sure that we're keeping our patients at the heart of those experiences. We also want to focus on teamwork, collaboration as a part of quality improvement. Quality improvement can't happen in a silo. It can't be one person trying to row the entire organization or practice in one direction. It takes all of us working together to move in the direction we need to go in. And so whether that's internal teams or even external teams with care coordination, when we're working with patients who deal with chronic conditions, they don't receive care in a vacuum. They are dealing with a lot of multiple subspecialties, lots of other clinicians, and so making sure care coordination between practices is smooth and that we're all working as a collaborative team together. And also, most importantly, data. And Vance will actually be talking a little bit more about data as we go on, but making sure that data drives our decision making, that we have good access to data and that we understand what our data means. And if we don't, that we find out and that we utilize data to help drive those improvements and make those strategic decisions. Additionally, why else is quality improvement important? And I think, first and foremost, it really helps us align and stay focused with IHI's quadruple aim in healthcare. So it really, it's there as that framework to help ensure that we're maintaining and improving the quality of care that's delivered, that we're improving patient experience, that we're increasing we're increasing operational efficiency and lowering total per capita cost, and that we're also bringing in employee and staff and provider engagement. You have to have all four of those things working together in order to see those improved outcomes. The patient safety, performance will all align if you're all working on those four things at the same time. And ultimately, it has a lot of downstream effects too. Not only does it improve your outcomes for patients, but we are moving and we are in the process of transitioning from that fee-for-service industry to a value-based care industry. And we see with CMS every single year that stair step, those thresholds getting more and more difficult. Whenever you're participating in the MIPS or the quality payment program, we see that trajectory and that path getting more and more difficult, and having that quality foundation of strong quality care is more and more important than ever, of having high quality care and low costs to be able to show value in care. Now transitioning a little bit and looking at the scope and drilling down here for the state of Kentucky. I'm not going to belabor this too much because I think most of us here in healthcare, we know the needs in the state of Kentucky. We know that we are number one in mortality for cancer deaths in the United States. We know the staggering statistics around it. We know that we have a lot of different factors, though, that are responsible for the reasons why we are, unfortunately, number one, number 5, number 7, but in the top 10 in a lot of chronic diseases and disease states. And, it traces back to, a lot of systemic issues, deep systemic issues around rurality, poverty, cultural issues, educational attainment issues. And it's a lot. It truly is. It's a lot to think about, and it's a big bite to chew. But our patients' care, again, it doesn't exist in a vacuum, and so understanding how it all interconnects, and we'll talk about that more here in a couple slides. This is just an example of just some of the disease trending throughout the state. And we can see, with both diabetes and stroke deaths, that it's not isolated necessarily to one particular region, that it does spread throughout the state of Kentucky. And so all of us working together to help improve outcomes for our patients, whether it's looking at improving smoking cessation, lowering BMI, looking at, trying to control diabetes, different things like that are all making impacts in our patients to improve their overall quality of life and health in the state. So transitioning over to, we see this problem, we know that this is a problem and an issue. How do you begin to address it? Well, there's been a tool that has been created, and it's been around, honestly, since probably the mid-90s, 95, 96, I believe. But it's the chronic care model. And I'm not going to go into too much detail with this today, but the big takeaway that I really want us to get out of the chronic care model today, and this is a tool that we commonly use with a lot of our practices who are looking at addressing, even if it's just a measure around some of the chronic care that we're dealing with, chronic disease, whether it's diabetes or asthma, stroke, but it's about linking health systems and community resources, because we realize that there are a lot of external factors that come into play with disease management, not just in the state of Kentucky, but just in general. And so if we can address those different factors to help bring resources to help close those gaps for those needs for our patients, they're going to have improved outcomes. If our patients are activated, if they're informed, if they trust their care providers, and if providers are engaged and prepared and proactive, it's all going to unite, and we're going to be able to see the outcomes that we want to have for our patients. And I've been kind of dancing around this, but that really, touches on what social determinants of health are. And so it's all of those factors about where a person is born, where they're living, the conditions that they're living in, their cultural experiences and background, their race, their gender, their ethnicity, lots of different factors that drive and shape who they are. And again, over the last couple decades, there's been a lot of research that's gone into social determinants of health as a driver for overall outcomes, and why it is so important to start looking at that and linking community resources with the health care that we're providing. Because research has actually shown that social determinants of health are actually 6 times more likely to determine a patient's outcome than actual clinical care. So them going to the doctor and receiving care is less of a driving factor than all of the other external forces in their lives, where they work, where they live, where they sleep, what they eat, are more of a driver for their outcomes than that engagement with their clinician for 15 minutes once a year. And so making sure that we are aligning, going back to that chronic care model of when we have that opportunity to connect, a patient with diabetes with diabetes self-management education resources, that's where we get that synergy. That's where we get that opportunity to meet them on the outside of the doctor's office, to be able to deliver and meet them where they're at and to meet their needs. Now that's a lot to unpack, right? That's a lot to unpack and to even begin to tackle and to look at as an organization. So I want us to kind of step back and think about, how do you begin to just solve even one problem, even one issue, to set one goal? And IHI has created the model for improvement, and this is, again, another tool that we use. It's a quick, easy tool that we use with our practices to really help them clearly define where they're at and where they want to be. And so you can ask yourself these 3 simple questions. What are we trying to accomplish? And that's simply declaring what your goal is going to be. The next question is, how do we know that a change is an improvement? That's identifying and selecting your measures. So if you're wanting to, improve diabetes, a logical measure would be looking at A1C pore control, right? And then what can we change that will result in an improvement? And so those are simply your change ideas. So if for patients with diabetes, you realize that you need to, work on creating more, opportunities around nutrition counseling for those patients. So that might be your change idea that you're going to test. So it's about thinking and doing. So there's a lot of planning that goes into and preparation that goes into quality improvement. Having a good, solid plan is really important. And so, and that's where the model of improvement really comes in. The next part is actually your testing and your doing, and that's that PDSA piece. And we'll talk about that more here in just a minute. Now, whenever you are going to set a goal, to make an aim, you want to make sure that it meets certain criteria, that it's a SMART goal, right? So it's specific, that it reaches that defined population of who, what, where, when, why, how. And it also is going to be measurable, that it's something that you can obtain data for, whether it's qualitative or quantitative data, but that you can actually get data for. It also needs to be something that's realistic and achievable, right? So you might want to be able to stretch for something, but you don't want to stretch so far that it demoralizes your team, right? And then you end up dropping the goal, because then that serves no purpose for anybody. You also want to make sure that it's relevant, right? So that it fits within the scope and parameters of your practice and what you're trying to do. And then also you want to make sure that it is time bound, that you give yourself a deadline to make that improvement. And again, we're going to be doing an activity a little bit later on around PDSA, so I'm not going to belabor this too much because we're actually going to dig into this a little bit more. But as I mentioned earlier, your plan area is really where you dig in and you do a lot of your work. You're planning, you're setting, you're identifying what exactly you're going to be measuring it, how you're going to be measuring it, you're who's going to be in charge of what aspects of your plan and how you're going to, run the logistics and that type of thing. The do piece is simply doing the work, making and recording your observations. The next part is the study part, and I know working with a lot of folks, they tend to want to skip that and they go straight to the, let's go ahead and go to the act piece and make our changes. But I think it's really important to stop and study and reflect back. Look back at, take your hypothesis and look at your results and see, does your hypothesis match your results, or did it vary? And how so? And how can you change that? How can you make that better? What tweaks, what adjustments can you make to that to retest again? And then you move on to that act phase and take what you've studied and then apply it to see if you want to adapt it and make those changes and re-enter a PDSA cycle. Or if you want to adopt it and you want to start scaling and spreading it to more and more areas. Because remember, a PDSA is a small test of change. It's what you can test, like we like to say, what you can test by next Tuesday, right? It's not a project. It is something small. It is something simple. And you build and build and grow it into that project from there. So just really quick to recap, it's important to make sure that we take note of our negative outcomes just as much as our positive outcomes, because those are opportunities to learn from. Our failures are just as important as our wins. Especially in healthcare, though, we want to fail fast and we want to fail hard, but we also want to get back up on our feet again very quickly. We want to make sure, too, that when we do have those positive changes, we actually spread them. It's really important to do that. Sometimes we let things sort of die on the vine. We get busy. There's a lot going on, and we want to make sure that we take, when we see something that works with it, in a small, isolated area, we want to test it and we want to spread it to other areas as well to be able to foster that change throughout an organization, because that's what actually leads to sustainability and continuity for our patients and for our staff and our organization. And so with that, I'm going to hand the reins over to Vance to walk us through data-driven improvement.
Might need to move that a little bit. Okay. Good morning, everybody, again. Glad to see everybody in person and not on a screen. It's good to have people with us online as well, so good morning to you all. Before I get started, I just kind of wanted to say, share a little bit of information with you all that myself and really my whole team, we've noticed over the past year and a half dealing with COVID and the public health emergency, really how impressed we are with all of our clients, even through all of these challenging obstacles that we've been facing over the past year and a half, how well people are still helping their patients and really making improvements in quality and meeting their goals, even through all of these other obstacles. So just been really impressed with that, and it just goes to show everyone how much people really care about what they're doing and helping their patients, and I think that's really is the reason that we all do this, is to help our patients. So we're very impressed with that, and I just wanted to share that with you guys as we get started. So data, it's really important. Why do we want to use data? Well, it helps to drive change. I found this really neat report from the American Hospital Association Market Insight report that showed how data can really drive change and what it can do. So with that, they found that it can improve patients' health outcomes. So you have healthier patients. You also have better patient care because of data. It can also help drive those costs of healthcare down. And then it also allows for that transparency by using that data and sharing it with your staff, with your organization and your team. That it really opens up that transparency so everybody knows what's going on. They know what their goals are by using data and by being able to see what the results are. So it really helps to improve that performance. And also it helps with the staff morality, just by being able to know what the goals are, knowing how everybody's doing it, it makes people more engaged. They feel part of the team, and they're more apt to want to do well and make those improvements. And then, of course, by doing all those other things, you're going to see that patient satisfaction and provider satisfaction. So all of that, because of that data-driven improvement, causes those different scenarios. Now, this infographic I thought was really informative because of all the different areas where data comes from. We get data from everywhere, and you all probably get all kinds of reports, whether that's through emails, through your EHR. It's just kind of thrown at you, so much that you probably can't even look at everything because there's so much. And one of the parts on here that I thought was very interesting was that in 2003, there was 153 exabytes of data that was sent out. And in 4 years, that grew from 153 to 2,314 exabytes. And 1 exabyte is equal to 1 billion gigabytes. So it's just like drinking from a fire hose, basically. There's so much stuff out there. What do you use? What's important? You know, we have all these origins where you can get it from. Like I said, your EHR, all kinds of quality reports you can use through that. You probably get all kinds of payer reports, insurance companies that you get chronic care patient lists that you can use, medication reports that you can use. And also you're getting data from wearables, from your patients are using their iPhone watch to get their blood pressure or their weight or their that kind of nutrition that can be automatically sent directly to the provider these days. And then also your smartphone, you can use diabetic journals for that. You can also get your blood pressure logs for that as well, and nutritional logs as well that you can send straight to the provider. So we've got all of these different areas and places that you can get data from. And in fact, they can come in different types of data. So you have quantitative data and you have that qualitative data. I think most of us are familiar with the quantitative. It's usually anything that's numerical, percentages, your performance on your A1C, pore control, your blood pressure, age, height, those kind of things. And then you have the qualitative data where it's non-numerical and it's more of a free form of a patient description or a patient response to a survey, those kind of things that you can get kind of an open-ended kind of a question response that you can use to make any type of improvement efforts. So when you get all of this data, what are you going to do with it? And IHI has a really good statement that it says an organization will not improve without a clear and firm intention to do so. So you've got to have a plan. And so you've got to start with that goal setting. And just like Jessica just mentioned about having that SMART goal, it being specific and measurable, achievable, and having it being relevant, and then time-oriented. So you've got to set your goals so you have that plan. And then once you have that plan in place, you're going to have to monitor that on a regular basis. And it's up to you to decide what goals need what type of monitoring. Maybe it's a weekly monitoring that needs to take place, or maybe it's annually. It's up to you to decide what is appropriate. And then, of course, feedback. If you're going to set goals and you're going to want your team to work on these, then you need to have feedback and let everybody know what's happening. And so that's where the transparency comes in. It's important that we have that feedback so everybody understands what the goal, if it's been achieved or if it's not been achieved, what needs to be improved upon, et cetera. So within that American Hospital Association's report, they had a group of data experts that came together and they came up with a really good suggested plan. And they kind of centered that and focused it around the quadruple aim and how to kind of put that in practical use. And so as you can see here, the quadruple aim is listed there in the bold gray verbiage. So it's starting off with improving populations. So by doing that, what can you do practically to kind of do that? So they think that you could have a better picture of your patient's health status. If you look at such reports such as like an ED use, your readmission reports, those kind of things, claims data that will really show that information for you. And then you can look at, work on your enhanced experience by looking at a patient satisfaction, your CAP survey, medical practice survey reports that you may have, and use that data to really drive that patient experience and those kind of things by stratifying that and looking at, maybe you want to look at different race and ethnic background data to do that, to improve that experience for the patients. And then, of course, reducing cost. So you might want to look at utilization reports, something like that. The cost of services are the services that you're using. Is that really improving the clinical care of your patients and kind of weed down what things may not be working well? So that is one example that you could do. And then, of course, improving work life. And that's really trying to avoid that fatigue and turnover of what everybody witnesses today. Everybody's tired, everybody's really stressed out a lot. So they really want to try to improve that and maybe do some, by using some predictive analytics and looking at that to try to help sway that stress and turnover. So if you're going to use data, we want it to be accurate. It's really important because if you do not have accurate and reliable data, then the people that you show it to, your providers and your team, are not going to trust it, and they're not going to think it's, it's really advantageous. So you need to make sure that it is reliable and make sure it's verifiable, and that you can retrieve that and that it is complete. Because without that, your team is going to lose some faith in you and your work. So you got to make sure that you do some data validation. Okay, so now I'm going to bring Jess back up, and we're going to do our activity. So while you're doing that, make sure this is the time that you make sure that you're logged in on your phone for the polling, because this is where our people in the audience will use their phone to do the polling here in the next few minutes. So make sure if you haven't done that, go ahead and do that. For people online, it is already going to pop up on your screen, so you don't have to log in into anything additional. So we kind of wanted to do something fun, a little relaxed, not about healthcare, so to speak, but kind of walk through a scenario for your PDSA and kind of have you all help us with this activity. And so we came up with a problem statement, and so we see Clark and Cousin Eddie up there at their Christmas tree. And so our problem is that we've been so busy with shopping and cooking and cleaning the house that we forgot to decorate our tree. So we've got 3 hours to do that before the in-laws get there, and you get caught with your tinsel down, and you're the talk of Christmas, and you don't want to be in that situation. So we're going to do this activity, and first of all, Jessica and I created the goal statement. So we went ahead and did that and already did the SMART goal for this. So the specific part of the goal is that we need to get the tree decorated before the in-laws arrive. And the measurable part, we need to do it within those 3 hours. And then it's attainable. We're all capable of decorating a tree. It's within our wheelhouse. And then it's relevant because it's going to allow us to complete the Christmas tree decorations and not be in trouble by the in-laws. And then, of course, we've got to do it by, we say 6 p.m., so within 3 hours. So we'll pretend it's 3 p.m. right now.
Alrighty. So whenever we actually set forward to do this little challenge and this activity for you, our original idea was we'll try to decorate a Christmas tree and go through that process. But in the planning of the activity, we realized that decorating a Christmas tree is actually a complex adaptive system, just like healthcare. That there are lots of parts and pieces to decorating a Christmas tree. You have to actually figure out what kind of tree you're going to get. You have to assemble the tree, especially if it's an artificial tree, and that can be a process in and of itself. You have to put the lights on. You have to, put the ornaments on. All those different moving parts and pieces that go into just putting a tree together. So actually, we are taking it apart and we're drilling it down into one PDSA that is just focusing on putting lights on the Christmas tree. That in and of itself is what we're going to plan to do as part of it, and realize that there are other PDSAs that are ultimately going to get us to our overall goal of, decorating this Christmas tree, but we're going to start with one aspect of it, of putting the lights on. So we are going to, part of our interactivity to link our people who are joining us virtually with our folks here in person today, is that we're going to use our polling feature. So if we want to go ahead and pull that up for everybody on the app, there might be a little bit of a delay for folks here and there, but we want to make sure that those first four questions are opened up. And what you're going to do is you're going to actually go through and you're going to select what the lights are going to look like. Are we going to use clear lights? Are we going to use red lights or multicolored lights? How many lights are we going to use? How are we going to wrap the lights around the Christmas tree, right? We're going to answer a couple questions to really develop our plan of attack for getting the lights together on this Christmas tree, because we understand there's a couple different factors we have to address in developing a plan. So we'll give you all a few minutes to online for our virtual attendees to do that polling, as well as our folks here. And then we'll go over the results in just a moment.
Looks like there's some responses coming in.
Yeah, we've got a few responses coming in. So keep them coming. Give you another few seconds to work on those. If anybody's having any difficulties, we have some folks that can come help you. Just raise your hand. Okay.
We'll give people a few more seconds to submit their answers on.
Alrighty, so let's take a look and see what plan we have collaborated with together and come up with as a group. So it looks like 66% of us decided we are going to use clear lights for our tree. All right, so that's part of the plan. And okay, we think so to decorate a 6-foot tall tree, we will probably need about 5 strands of 20 foot long, so about 100 feet of lights to decorate. So lots of lights. It's going to be a really bright white tree. You're going to be able to see it, right? We know that. Alrighty. So then next, it looks like we've picked our methodology for wrapping, right? Because you could either just like throw them on the tree, you can just do them up and down. But we decided we're going to start from the bottom. I have never done that before. I'm going to have to do it this year. Yeah, I start from the top and go down. It blew my mind when he was telling me all these different options. Do you know there's a TikTok thing where you can string them up and down like this? I saw that this year. Sorry, I'm losing my mind. But yeah, start from the bottom and wrap from the top. So that's what we're going to do. And do we have it all?
And then will you plan to test your lights before you?
Oh, no, we're not going to live dangerously. We're actually going to test our lights before we put them on the tree. So go you all. That's awesome. So that's our plan. That's our plan of attack that we are going to do whenever we put lights on our tree. Okay, so that's our formula. So I'll take it over to Vance to talk about the do part.
Okay, so now that we have our wonderful plan in place, that is going to take most of your time in this, in a PDSA will be the plan phase, is so that you can get all those specifics down, decide what you want to do, and the more that you have that planned out, the better you're going to be prepared for the actual activity. So once you get that done, then it's time to actually, put it into place and implement the plan. So you're going to do that, make sure everybody knows their job in this for stringing the lights. And then the most important part is to make sure while you're implementing it that somebody's going to be observing and tracking what's going on, because that's going to be your most important piece. So when you go to assess everything, you're going to have something written down and your observations taken care of. So we're going to bring up our next poll for this. So as we start to string our lights here, we're going to ask for them to open up that next polling question. Let's see here. So if you guys will go ahead and get started on that. What do you think? What are some important items or activities that would be helpful to observe and track? So if you all can start doing that.
I think it closed already.
You have to go back and then
Okay.
Okay. So it should be pinned at the top?
Yeah, I think they moved it to the top so it would be easier to find.
Great.
Yeah, that was a little confusing, wasn't it? Give you guys a few more seconds. And it looks like that you all said that we should do all of the above to observe and track all of that. Were there enough lights used to cover everything? Were the lights hung appropriately? Were all the lights working, etc.? So that is probably the best answer, that you want to make sure you can make all kinds of those observations, because as you find out and assess from this, you may want to piggyback off of what you've learned from this to maybe do another sprint to even make some more improvements.
All right, and so then the next part is that you want to take those observations that you've recorded, and you might find that you've actually looked at something else, another factor that has come up and been an influencer that you didn't initially think about, but you want to study that, you want to take a look at that. You want to review for, what worked well, what didn't work well. And you want to then look at your data and look at your overall outcomes. Maybe there were some other factors that you didn't think about that are an influencer as well. Maybe you have a power outage and it's not going to work at all. So different things like that are going to be influencers for your overall outcome for your test of change. So what we're going to do here today is this is going to be a little bit of a choose your own adventure. Based on this PDSA, because we can't decorate a real tree right here, to see how this went. But what we're going to have you all do is just vote on what you think, based on your plan, based on the test of change, what would have been the scenario from the outcome for this particular plan. So we're going to open up that poll question for the study piece. And again, it should be pinned to the top. And we'll let you pick what you think would be the scenario that would come from this particular activity that we're doing. See, a few people are choosing that they gave up and went to watch A Christmas Story. I totally understand your frustration with tree trimming.
The lights are the worst.
They are the most unfun part of it. Alrighty, looks like so far though we do have the majority felt that we underestimated the amount of lights needed. 100 feet just was not enough. We really want it to be seen from outer space. So we're thinking, we'll make next year when we have the opportunity, we're going to wait on clearance, we're going to get another 100 feet, and we're going to have 200 feet of lights, on this tree next year. And that's what'll be our next test of change when we do this sprint again, right? So then we'll move on to the act part and what our recommendations will be.
Sure. So now that you've implemented the plan, you've studied it, so now what are you going to do with everything that you've assessed and observed? So are you going to adapt that? Is it something that worked pretty well, but you want to make some tweaks, revisions to? Then you would adapt it. Maybe you want to completely adopt it. It was perfect. Everything worked out well. I don't think in the choice that we chose, we would fully adopt it at this point, but maybe some people thought that you were ready to go and fully adopt it. Or if it completely was a bust, for those of us that went to see Christmas Story and ate some popcorn, then you would just completely abandon that plan and probably start completely over for next year. So that's what you want to decide. And so based upon what we've talked about today and our decisions that we made, what are some things that you think you could do to improve that, improve the plan for next time? What observations did you see or think about that in this scenario could happen? How could you make those improvements, those changes? And so if you will enter those in the chat box, for those of you online, and our REC staff is going to kind of help us know what people are answering since we can't see it up here. And then here in the audience, so feel free to share with us what you think some observations could have been that you would maybe change for the next time. What do you all think? Have more lights? Buy more lights.
Buy new lights?
Go to Lowe's again.
But there we go. We got some innovation there. Save us some time.
Free lit tree, yeah. I have a pre-lit tree with additional lights that I put on myself, so. Are we getting any responses online from people, guys?
Buy more lights.
Buy more lights, so that seems to be going to be part of our plan next time.
Pre-plan.
Pre-plan?
So don't wait till last minute, okay?
Yeah,
Yep. Okay.
good idea. All right, well, those are some good ideas. We'll go ahead and move on to our next part. So thanks, guys, for participating with us on that. We appreciate it. Tried to have a little fun with this topic and try to move away from healthcare a little bit to get our minds engaged a little bit. So now we kind of want to move into some practical aspects of quality improvement and how we have seen that, witnessed it ourselves with working with clients across the state. So kind of what we want to start with, one of the models that we have liked to use and we've seen some good success with is a learning collaborative. And so this is part of IHI's Breakthrough Series model. And really that model kind of combines three different models into one. A learning model where people come together and they network with a group of experts for the participants. And then it combines with that chronic care model that Jessica talked about a little bit earlier that really delves into how to handle chronic disease the best ways. And then the model of improvement with using those short sprints, that PDSA cycles. So that collaborative, it kind of molds all three of those together into one. And as a visual, we kind of shown you how that collaborative model works. So you would start off with, selecting your topic, whether that's diabetes or maybe an asthma, PCMH, something like that. You're going to recruit your team, the faculty that's going to be part of the collaborative for the experts. And then you're going to develop that framework, how that model is going to work for that 12-month process, 12 to 14-month process, something like that. Then you're going to start, enrolling participants who's going to be a part of this, and then plan for that, do that pre-work that somebody just suggested doing, so getting that pre-work done before you actually start. And then when you start, you're going to do what we have learning sessions. So we usually have about 3 learning sessions throughout that 12-month period. And at that learning session, everybody comes together, part of the collaborative, to share their improvements, their successes, challenges, any barriers that they've had, get some education, some additional resources during that time. And then after that learning session, we move through what we call that action period. And at that time, that's where the participants are working on their own with their own individual teams, and maybe they have a coach that they're working with during that time in between the learning sessions, where they have monthly meetings, monthly webinars. They correspond through emails, phone calls, those kind of things. And then in between those, during those action periods, that's when you're going to be testing your interventions and those sprints and doing those PDSA cycles in between each of those learning sessions. And then at the very end of the collaborative model, we come up with what they call a summative congress. It's a real fancy name. So that, again, everybody comes together for one last time to kind of share the results, their final results for their years-long worth of work, and talk about their successes and, again, their challenges, tips for everybody, and, again, additional and final resources to kind of boost them through as they kind of propel without the collaborative moving forward. So now I'm going to pass it to Jessica. She's going to share with how we've used this model here.
Sure. So in particular, we have done a lot of focused work around diabetes and, partnering with the CDC and DPH for the Diabetes Learning Collaborative. And this is a 14-month process that does adopt the IHI Learning Collaborative model. So we have those learning sessions where we all convene and come together, whether it's virtual or whether it's in person pre-COVID. And then they break apart. They work in their small teams, like Vance mentioned, and they do small cycles of change, testing what they've learned in those big sessions or during our monthly practice calls as well. And then we have coaches that help support them. We have a Healthy Living with Diabetes partner that is from the, that's a diabetes educator that is from the health department in their local community that meets with them monthly to also help provide resources and help link them to that diabetes self-management education so that we have a good, strong relationship with the changes and the care that they're trying to deliver at the clinic, like we talked about with the chronic care management model, as well as, you know, partnering with them with those community resources so that they can help meet those patients' needs outside of that healthcare setting. And then just to talk to you about some of the outcomes that we've seen, it has been phenomenal. So these are the results from our first learning collaborative, our first cohort that actually transitioned to virtual in the middle of the COVID-19 pandemic. And they still continued and stuck with it. You know, Mary's here, and I know she's proud as a peacock of them and all of the hard work that everybody did as a part of that project to still have tremendous outcomes in the middle of such dramatic change. And so you can see evidence there that we saw tremendous leaps in the amount of DSMES referrals and attendance. It was about bringing awareness of resources in the community and awareness of best practices, really, in evidence-based medicine. And practices soaked it up. And it's been a fantastic opportunity to get to partner with practices and organizations across the state on this work.
Yeah, so really great work with that Diabetes Collaborative, and we're continuing to see that in the current collaborative that we're working on now. Our practices are doing some really great work currently. So another collaborative approach that we've done here is at UK, we've instilled what we call the quality initiative or a diet initiative that we've started with our ambulatory clinics that we help out with. And so with that project, some of you all might be thinking, what is a diet? And we'll get into that in just a second. But it's on that same model. We run this on an annual period, and it runs from our fiscal year from July through June of every year. And so we have monthly collaborative meetings where all of the clinics and their diet pairs come together to discuss those different resources and educational pieces and those kind of things. We also have monthly coaching meetings. Each of the clinics have an assigned practice coach that helps them throughout the year on their goals that they are working on and helps them with the sprints that they have to submit on a monthly basis for that. And we have additional calls and support too if the clinic it's needed. So really a dyad, it's just pairs of a physician and usually some sort of administrator that really help champion their team of their own clinic and kind of propels them forward throughout the year to help them set the goals and help with sprints, those kind of things. And usually the dyad pair, on an average basis, it's normally the medical director of the clinic and the practice manager. So those two head up that as a dyad pair and then work with the entire staff throughout the year. And at UK, we focus on those 4 areas that you see for the goals of the exceptional care, safe care, and extraordinary engagement, and then efficient care. And so these are some examples of the goals that our clinics can choose, that they're able to choose. Our specialty clinics, they have to choose at least 2 goals for the year. And our primary care clinics, they choose 3. So they get to choose this option out of this. And there's other ones that they can choose too as well. But this is just a sample. And then Jess is going to talk about the outcomes.
Sure. Well, I think, we had some really strong, great outcomes from this work and this partnership. One of the first things whenever we were starting this work was to really have our team speak a common language and a common quality improvement language. And so shared education was really an important driver in that work. And so we put forward a lot of folks, over 600 of our frontline and leadership through quality improvement methodology and education. And so that was a big lift and a big ask from the organization, but they committed to that. Having that leadership buy-in to really drive cultural change is really crucial to adopting and implementing quality improvement and creating a cultural foundation for it. Through the first year of this work, we saw tremendous improvement around just depression screening, a 20% improvement, over a 4% improvement in tobacco cessation, and over an 8% improvement in colorectal cancer screenings alone. And the work continues to evolve and grow as well. We saw, improvements around efficiency and staff and provider engagement as well. That was also another measure. Having them engaged in the work, I think, really has made a significant impact and difference as well. And then just some other highlights that we really feel, were really beneficial to this particular project was having set enterprise priority goals that then cascade down to those individual clinic areas and having that alignment with enterprise goals and our dyad leader goals as well. And then also, I think, transparency of data, being able to share data and data in a judgment-free way, that it wasn't about it wasn't punitive. It was about learning and growing and understanding your data and the processes around it, and getting dyads to and our leaders, our physicians and nurse champions and practice managers to start validating data and really drilling into numerators and denominators and understanding how our reporting works. And we're seeing that continue to evolve and deepen and as the project continues. And again, that's always going to be an area for improvement and getting more and more access to data and more data that they need to drive that change. And also some of the feedback that we did receive from dyads is they want opportunities for peer learning in their collaboratives. They want to be able to share their opportunities for improvement and what's working well and what isn't working well, and to be able to get that feedback and that collaboration for each other. And so those are some of the main areas that we are continuing to always evolve and to grow and expand for this work.
Yeah. Really good stuff going on with that. And as the next slide here shows, it's the patient-centered medical home. The New England Journal of Medicine had an article that states that they feel one of the ways to prepare yourself or your organization for value-based care models is by becoming a medical home. And for those of you all that don't know what a patient-centered medical home or a specialty practice is, it's not a specific location or anything. It's actually a model of care. So it's patient-centric, centered around the patient, what the patient wants, around their goals and their challenges, and it's around that, them and their provider and the provider's team for the patient. And so it's basically a roadmap of how to implement this model of care into your practice. We use NCQA's Patient-Centered Medical Home and Specialty Practice program. They're kind of the gold standard for patient-centered medical home recognition. And so we use that. We use their standards and guidelines to kind of drive that in order to build that infrastructure within your practice and organization. Most people that begin this journey are already doing many of the things that are already needed to become recognized. They just need some different revisions, some minor tweaks, some written processes to get that into place to become recognized. And so NCQA did a study a few years ago, and they found that these are some of the cost benefits that they've found associated by being a medical home. And as you can see, there's some really great cost savings associated with this, such as lower acute hospital spending at 62%. I thought that the Medicare spending per beneficiary of $1,099 was very interesting. And then, of course, reduction in your ED utilization and ambulatory care sensitive inpatient admissions. Now, working with our practices here locally, one of my practices just submitted for their annual renewal for their recognition, and they have to do quality improvement as part of one of their core competencies for the program. And so by becoming PCMH recognized, you are kind of building that QI structure in your practice with this model. And so they have to do these small PDSA cycles and choose different clinical measures, different patient experience measures, resource stewardship measures, and access measures when they become this. And this is some of the success that we've seen with this one practice. They just, for their breast cancer screenings, they went from 43 to 48% in about a 3-month time. Their high blood pressure, controlling that, went from 60 to 67%. And then, of course, you can see their access by using their CAP survey and their patient experience data. They were able to move that from 83 to 97% it was actually on patient wait times in the office. So really great work with that.
And then, of course, we've spent a lot of time looking at it through the overall outcomes and that patient lens, but also payer performance optimization is a critical component for, a practice or for an organization as well. And so we know that, again, and I think I touched on this earlier with CMS, that we see that increasing threshold for penalty avoidance in 2022. We're now looking at a minimum of 75 points. And so it's becoming more and more critical to hardwire quality within your organization to make sure that you have, really strong performance in that area and that you're focusing on aligning quality and cost for that to be able to be successful, because the penalties are becoming very significant and it is becoming just more and more difficult to be able to reach a positive payment adjustment with this program. Also looking at, private payers as well. There's a lot of opportunities. Talk to your private payers that you're partnering with. Look at your contractual agreements and to see, if you can capitalize on your per member per month reimbursements, because there's a lot of alignment between these programs that if you can make some improvements across a couple different measures that fall in line with a couple different payers, you can receive some additional reimbursement for that. So start having those conversations with your payers about what measures are important for them that they are looking at and that they're offering extra incentives for, so that you can capitalize on some of that work and you can align it with some of the other programs, whether it's HEDIS or the quality payment program, so that you're all moving in that same direction and it doesn't feel quite so scattered when you're working on your quality improvement efforts as well too. So lots of opportunities there. And then additionally, where do you start? We've thrown a lot of information out at you today. I know that for sure. But the most important part is first of all you have to take a step forward. Right? You have to look at your organization, look at your practice, and you have to think about, what methodology are you going to choose? What are you currently using? If you're already using something, does that meet the needs of your practice? Does that meet the needs of your organization? Are your staff already trained on that? And how have you communicated that out? And it doesn't really matter what the methodology is, but you want to make sure that you're using that and that that's open and transparent and that you're sharing that, and it's not just leadership driving the change, but it's cascading all throughout that organization for it to be meaningful. And you want to make sure that you're communicating those changes, you're engaging your staff, you're engaging your providers to be a part of that process as well. Again, too, we want to make sure that we create a plan and that we have that continuity with it. Nothing is more frustrating than we start something and we stop something and we don't ever pick it back up again. And so that's one of the main tenets, right back to thinking about that HRSA definition for quality improvement, is that it's continuous. Right, so we might have to change the plan, we might have to adjust it and augment it for our needs, but that we are following through with it. And again, I mentioned this earlier, it is okay to fail, right? It is okay to fail as long as we fail fast. We pick ourselves right back up. And we start that next cycle of change again, because we want to make sure that, while this is a journey, that we are learning from our mistakes just as much as we're learning from our wins. And finally, we want to make sure that we don't over-engineer, we don't over-process or over-complicate something. So we step back and look at, is this really an improvement? Does this make sense, this change that we're going to implement? Does this make things, more understandable, more easier to process and to do? So again, don't over-engineer, don't over-complicate.
That's easy to do, isn't it? So start now. That's the best time to start. If you haven't started any type of quality improvement efforts in your organization, go ahead and start that now. We have found that most people are already doing this, even if they don't realize they're doing a PDSA. They're already doing that in some sort of fashion. So go ahead and kind of grow that and work with your team and get things going as soon as you can to make those changes, because it will make a difference. So that brings us to the end, Jessica.
I do, and I think we might have a few minutes for questions if anybody has any questions for us.
And online, if you have any questions, feel free to put those in the chat. You all are a quiet group. Okay, well, if you think of anything, we're going to be here all day, so just grab me and Jessica, and we're happy to help answer anything. Thanks so much, everybody.
Thank you. There you go.
She's about my height. Good morning, everybody. Is everybody awake? Yes? Does everybody need more coffee? Probably, yes. Well, good morning. My name is Kelly Fountain. I am the Quality and Value Manager at the Kentucky Regional Extension Center, and I have the great honor to introduce our next speaker. So Jessica Sass is the Director of Ambulatory Population Health at UK Healthcare, and as well as being a nurse practitioner for the Family and Community Medicine, Jessica has focused most of her work on transformation care, population health, care transitions, and quality improvement. In most things that are centered around quality improvement or really driving care for patients, Jessica is kind of at the center of that at UK Healthcare. So we are really, really honored to have her here to speak on the transformation that she's really driving the change at UK Healthcare. Right now, she's in the middle of it. For the last almost 2 years at this point, she's really been kind of on the ground building population health. And a lot of you may be thinking, but UK is such a big institution. It is, absolutely, but they had to start somewhere. And they do serve a very, very complex, very sick patient population. So there's a very much a need for kind of having a strong and robust population health system. Sorry, I'm ad-libbing Jessica, but Jessica is also working on her doctorate right now at UK for nursing. Let's see. She's also a licensed advanced nurse practitioner and since 2004 and has worked in various settings, including Critical Access Hospital in rural Northeast Kansas, providing care in primary care clinics, emergency departments, and inpatient settings. Health departments in women's health program, as well as an urgent care facility and a level 1 trauma emergency department. So I think Jessica has a wide variety of providing healthcare services. So everyone, please welcome Jessica to speak on population health.
All right. Well, thank you. I'm going to move this a little bit, I think. I want to be able to see you guys. Okay. So I am excited to be here to share with everyone what UK Healthcare is doing around population health, but also to discuss ways that you can implement population health in your programs using the quality improvement principles that we are talking about. The first thing is, what is population health? So basically, it's health outcomes of groups of people and the distribution of those outcomes. And we know that those outcomes are largely dependent on social determinants of health. And as mentioned earlier, the social determinants of health are conditions that are affected by the environment that then affect the quality of life of people. And why do you want to do population health? Well, basically, it goes back to the quadruple aims. So you can do quadruple aims for quality improvement, but you can apply that to population health too. The exceptional clinical care, engagement, patient satisfaction, reducing cost, also improving work-life balance for your clinical staff. And then up here, we also have education and research. UK Healthcare is an academic medical center, so those are, along with clinical care, pillars of the strategic plan for 2025 for UK Healthcare. Leadership for the population health program is myself as the director, and then Julia Byerly is our nurse manager over all of population health. And as UK Healthcare developed their 2025 strategic plan, population health became a focus. We could not even begin to think about meeting our objectives without focusing on population health. And I will say population health at UK Healthcare on the ambulatory side started very, very small inside of family and community medicine. It started with our TCM program, our Transitions of Care Medicine program, and Julia, who is now the nurse manager, was our sole nurse doing that program. And she was calling patients after discharge to make sure that they had a good transition between the hospital to their follow-up appointment. A few years after that, we implemented panel management. We hired a panel manager to really manage our provider panels and help with continuity of care for our patients. About a year later, we hired a chronic care management nurse to do monthly phone calls, and then we also hired a community health worker to help with the barriers to care. I will talk about all of these programs a little bit more in depth as we move through the presentation. But what I wanted to show is that we started very small inside family and community medicine, and this is what we look like today. This is our patient-facing care team, and then the panel managers, they're not pictured on here. They work a lot behind the scenes to make sure that we can provide the care to the right patients at the right time. And then this is our reach at UK Healthcare. Currently, you have the population health team in the center, and then how we branch out to primary care clinics. We're also working with some of the specialty clinics, our urgent care clinic. We work with the CATS program, which some of you may have used to transfer patients to UK Healthcare. We have a focus on our high-risk patient population. We're working with our discharge clinic, which is relatively new, and we'll talk about more later. We work with both Good Samaritan and Chandler Hospital. We work significantly with our community partnerships, payer contracts to provide quality, safety, care, and then overall improve the health of our communities. So the path to population health is very similar to the slide on why do you want to do quality improvement. You're going to have a targeted population. You need systematic and continuous action. You need to be able to do some data collection, process that data, and analyze it for steps forward. Our first program I want to talk about today is our Transitions of Care program. So as I said, it started with Julia, one nurse. We've scaled now to 4 nurses, and we are adding 2 more in January. Their main focus is calling patients that have been discharged from the hospital within 24 to 48 hours and reviewing the discharge instructions, medications, follow-up appointments, making sure the patients knew about that. They were able to get any of their durable medical equipment that they need. If they have questions about their care, that they can answer that. If they're having symptoms or issues after they've discharged, they can manage that. They can move the discharge appointment up if needed. So they really are bridging that gap between hospital to home and then on to that follow-up appointment with their primary care provider. Why do you want to do TCM? Why would you want to do a transitions of care management program? To reduce 30-day readmission, to improve coordination of care. It's an asynchronous care program that can relieve some of the burden off your providers, off of your frontline staff in the clinics, and then also it's a billable service. And so thinking about those 4 things really take you back to the quadruple aims, striving for the quadruple aims: quality of care, engagement, reducing cost, the patient experience. And then thinking through all of that, you would work to set your aim, select your measures, develop your change ideas on why you might want to implement a TCM program. I do want to mention that in implementing some of these programs, if you are in the beginning stages of implementing some of these programs, your focus really will be on the logistics, the operational pieces of whether or not your facility, your clinic can implement some of these things and what that might look like. If you already have a program in place, then you really are going to look more at those specific outcomes. What are the specific things that you want to improve? So implementing a TCM program, you certainly would have to know when your patients are being discharged from the hospital, when they're in the hospital and when they're being discharged. Sometimes that's a difficult thing to know. You might not know that until the patient calls for a follow-up, or maybe the hospital calls your clinic and wants a follow-up, but you have to be able to know those things. You have to be able to know how many discharges you're having in a day, in a week, in a month. How much time is that outreach going to take one person to do? Do you have key personnel to do that outreach? Who can you pivot? Who do you already have employed that maybe you can pivot their role just a little bit to provide this phone outreach? You would need to know the CMS billing requirements. You certainly don't want to do all of this work and not reap the benefits of the RVUs. And then, again, the last 2 points down there are more if you are implementing this program. You have to think about a workflow, process maps. Can this even be done in your clinic? And then your change ideas will be mostly related to implementing the program versus a change idea to provide a method of change. Again, if you have a TCM program, maybe it's something that you want to improve as no-show rates. Maybe you have a 50% no-show rate and you want to make that a 25% no-show rate. So what can you think through to make that change? You want to establish your baseline, set or identify your priorities for working through that improvement idea, and then set your goals. And remember, they've talked about the SMART goals. Always keep your SMART goal in mind. You don't want to set something that's not achievable, timely, relevant, measurable, and you need to be very specific about that. This is what we are using as our TCM workflow for our discharge clinic, which we'll talk about a little bit later, but I just wanted to throw this in here because it is important to have a good, solid process or plan for implementation. And then that way you can look through your process map and say, oh, well, that's not really happening, or, oh yeah, this is working really well. So I threw that in there just as an example. Chronic care management. This is a program for patients who have 2 or more chronic healthcare conditions expected to last 12 months or more. It's a specific outreach program by a registered nurse to work on patients' healthcare goals. coordinate their care between specialists, whether that would be counseling or cardiology, neurology, help connect with community resources or community groups that might be beneficial to that patient, assist with medication concerns, answer questions regarding the patient's health conditions. They provide self-management education as well as just education around that disease state. So why would you want to implement a chronic care management program? It's very similar to TCM, improved care coordination, the asynchronous care, improvement of chronic condition outcomes, and then it's also a billable service. And again, these 4 things can be tied back to the quadruple aims. And then if you wanted to work through implementing a chronic care management program, you're going to think about the 3 questions from the IHI model of improvement. What are we trying to improve? How will we know improvements occurred? And then what are the change ideas for making sure that improvement occurred? You'll set your aims, select your measures, develop your change ideas, and then you're going to move into the planning phase. And I do want to say that sometimes the thinking, those 3 IHI questions are the thinking stage, and then the plan, starting with the plan, is kind of that doing stage. A lot of times the thinking and the plan stage overlap, but that's where you want to spend a lot of your time, is in the thinking and in that planning stage. So for CCM implementation, it's very similar. You have to know who your patients are with 2 chronic conditions. You have to know the CMS billing requirements. You need to make sure that you have an EMR that can support this type of documentation. You need to also have key personnel for outreach. Now, one good thing is if you wanted to do a TCM program and a CCM program, you could use the same person, at least initially, because you're not going to have tons of patients that you are outreaching to. So that could be the same person. And then you will work to establish what your baseline is, identify your priorities, and set your goals. So if you don't have a program, again, think about operationally, logistically, what are the things you need to think about to make this happen? If you have a program, maybe you have enrolled 20 patients, but you would like to enroll 50. So then that's where your change ideas will come from. How do you increase from 20 to 50? And then you'll just move on through the PDSA cycle until you've decided to either adopt, adapt, or abandon. Our next program is the quality program. We have 7 clinical quality technicians that work in our quality program. They are servicing all of the primary care clinics at UK Healthcare in various ways, and they basically work to close care gaps for patients. They reach out for preventive screenings, well child checks, immunizations. They will also help coordinate chronic condition appointments, and then work with our payers for the care gap reports. One of the things, too, that the clinical quality technicians do is they work with those dyad groups that Vance talked about. They work with the medical director and the practice managers to help them meet their goals. So we collaborate with them for that. Why would you want to start a quality program? To improve your preventative screenings, to improve your preventive visits, whether this be well child check, health maintenance annual visits, or your Medicare wellness visits. You can focus on chronic condition follow-ups. Maybe you have patients that don't come in for their A1Cs when they should. You can also improve your star ratings through your payer programs with a quality program. In order to implement a quality improvement or a quality program, you would want to think through a couple of different things. What do you want to improve? What do you know that you can start to improve a program? So say you want to improve your care gaps for mammograms. Only 50% of your patients are receiving the mammograms that they should, and you want to improve that up to 75%. Well, do you know what your mammogram gaps are? Do you know those patients that have that gap in care? Do you have personnel to outreach to them, which certainly could be someone else that you're using for another quality program? It could be your triage nurse if you have one of those. Maybe the front desk has some downtime. Maybe a person there in the afternoon could outreach to 10 people a day. So just think about logistics and how you could pivot some of those staff that you already have. Does your EMR support this? That's a big thing. You really need to make sure that you can be supported through the EMR. Access to payer reports, that's helpful too. If you don't have access through your EMR or that data, then your payer reports could really provide that data to you. And then, again, it's all about logistic planning, implementation, and then thinking about those change ideas that you really want to do. Think about what it is that you want to accomplish, what's important to you, and then set your aims, define your measures, develop your change ideas, move into establishing your baseline, identify your priorities, and set your goals. You can also do this for diabetes management. And if you are really gung-ho, you could have a chronic care management program that's focused specifically on your diabetic patients. Otherwise, if you don't have all those resources or you don't have any of these programs in place, certainly just think about what you can do to help manage your diabetic population. Do you want to focus on the diabetic eye exam? Do you want to focus on those patients with A1Cs greater than 9? What is it that you want to improve? What is it that would benefit your practice? What is it that would benefit your patients? And then panel management. This is, I would say that this is a little bit of a difficult concept to grasp. What does a panel manager do? Why are they important? Well, I will tell you that our panel managers know the ins and the outs of our patient population, the numbers of patients who are unique to our practice, the number of visits per day, the number of visits per week, unique visits, new patients, established patients, the number of no-shows that we have, the number of same-day cancels that we have, the number of same-day appointments that we have. They know all of this information. They also know that provider X has 1,800 patients on their panel, or provider Z has 500. They work to make sure that providers that are not up to their benchmark for their provider panel are open to new patients so that they can build to their panel. If they're 20% over their benchmark, they close their panel so that they do not take on any more new patients. It helps with patient access and throughput. So they really are the behind the scenes keeping everything together and moving forward. They also work to maintain patient continuity so that if I have a patient in the clinic and I'm their primary care provider, that if I have an opening that they're seeing me and not someone else. Now, if I don't have an opening, then certainly, getting them in with one of the other providers in the clinic, but patients like to see their providers. And so this is one of the ways that we've been able to improve continuity for our clinics. They also allow for feedback. So this is the feedback that Jessica and Vance were talking about. When we know which patients belong to which providers, we also know what those patients are saying about their providers that they're seeing. We also know what those providers are doing for their quality improvement metrics. So what percent of my patient population has their mammograms or their colorectal cancer screening. And so that information is very important, and it's important to be right when you want to roll this type of a program out. Again, helps with the access, helps identify scheduling concerns. You know, we can't get anybody in. Why can we not get anybody in? Visit performance. You know, you have 5 health maintenance visits on your template, and you're only using 2 of them. Or it also helps to establish what certain providers are doing with their patient follow-ups. So maybe you have a provider who's scheduling everybody to come back and nobody can see them for 6 months. So those are just helpful things that panel managers can help identify within your clinic to improve access, continuity, throughput. Again, you know, this person truly has to know the EMR inside and out. They have to be very savvy with Excel. It's a lot of downloading the data and manipulating the data to get these answers. The panel managers also are helping a lot with demographics of patients for us to be able to identify, you know, what percentage of our patients are X, and can we outreach to those patients specifically. And then again, a key personnel, but like I said, this is kind of a difficult concept to grasp. It's a difficult concept for leadership to agree to pay for a person to do this kind of work if you haven't done it before. And so start small. If you think that this would benefit your program or your clinic, certainly start small. Do you have someone who can monitor the no-show rate? Do you have someone who can monitor your new patient appointments? And maybe you already do something like that, but what new patient appointments are no-shows? This would also help improve access for your clinic. So you can certainly start small, and if you don't want to hire this position, do you have someone who has Excel knowledge that might be able to do some of this data manipulation for you? So just think about who you already have in place that you might be able to ask them to do a little bit more as far as identifying patient populations. How many patients are on each individual provider's panel? Our next program is the Elder Care Navigator program. Candy works specifically with our patients who are 65 years and older, and they typically have come to her because they've come to the emergency room. So she will monitor the emergency room visits of patients looking for those who are 65 and older, and then she will outreach to those patients who may have care barriers. She's also a certified dementia care navigator, so she works a lot with patients or caregivers of patients with dementia, but just really trying to decrease those barriers to care. She will provide medication assistance, transportation assistance, housing assistance, or at least connect them to resources that can help them. Why would you want to have someone do this? Well, we know that healthcare is confusing. Navigating the healthcare system is very confusing. It's even more confusing for our senior population. Everything has become automated or through a smartphone, and they don't do a lot of those things. Now, some of them do, but a lot of times they don't, and that's hard for them. And so Candy really spends a lot of time making sure that they understand that they have her as a support, that she can help them reach out to community resources, establish transportation, even housing. The payer reports, if you don't know who's going through the emergency room, payer reports will provide you ED utilization for your patients, so you could use that. I think one thing to really think about is the number of patients that might fall into this category if you're wanting to implement a program, and the time for outreach. so that you don't say, oh yeah, we're going to reach all of our patients who are 65 and older, because it does take a little bit of time to outreach and work through these community resources. So certainly thinking about that up front is important. Our community health workers, our community health coordinators, we started this program probably in 2019, and I will say that this has been a little bit difficult of a program to get up and going. We were hitting our stride with community outreach and home visits about the time COVID hit. And then we sort of stopped all of that. They would go and see patients in the hospital, they would meet with patients in their home, and so we stopped that obviously during COVID, and we started doing telephone outreach only. We are certainly getting back to doing a little bit more community outreach and home visits, but the community health workers really are that liaison for community resources and that patient advocate. This position really works with those social determinants of health factors, the things that prevent patients from getting the care or being able to access the care that they need. They assist with food, housing, transportation, job placement, referral to substance abuse counseling, mental health counseling, just a wide variety of things that the patients need that Vance and Jessica also talked about, that they don't happen inside the four walls of the hospital room or the clinic room. These are all the things that affect a patient's quality of life that we cannot take care of inside of a clinic or in the hospital. This is just an example of our process map for referring to CHWs or elder care. And then what I like about this is we've built into our process how they can refer back to our chronic care management program or other programs at UK Healthcare to continue to care for that patient. Innovations on the horizon. So the discharge clinic, this actually went live about a month ago. We realized that inside family and community medicine, when we were starting that TCM program, collecting data, running through quality improvement, PDSAs, we realized that patients that were admitted the most, readmitted the most, were those that either had a PCP outside of UK Healthcare or who did not have a primary care provider at all. And so we wanted to be able to provide a place for those patients to follow up. And that's where the discharge clinic came from. They have to have one of the 5 diagnoses listed up there or a risk score of greater than 26 to come through the discharge clinic. But it's specifically for hospital follow-up and for patients that do not have primary care providers. Now, one good thing that we've done is if the patient does have a primary care provider at UK Healthcare, but they can't see them within 7 days and they're a high-risk patient, they can flip over and be seen in the discharge clinic. So this is pretty exciting. We're still in implementation stages. Like I said, we're about a month in, but so far it's been a positive experience for our patients. And then that led to the next line there, the non-UK healthcare patient pilot. So there are certainly patients that come to UK healthcare that don't want to follow up at UK healthcare or have a primary care provider outside. And so then we wanted to be able to assist these patients in having follow-up appointments. So we have some MHA students that are going to help us with this pilot to see if we can improve 30-day readmission in this patient population. So stay tuned. We will give some updates on that in the future, but I'm excited about this program. The other thing that we're also working to do is this Retain Kentucky, and I don't know, it's a grant. I don't know if anybody out there has heard about it, but it is a federally funded program that is through the University of Kentucky. There's a large group of people working on this grant, and really what it's designed to do is keep people at work or return them to work after injury or illness. Now, they really cannot be on short-term, long-term disability, but they can certainly be struggling with their current role. So maybe they've had a stroke and they just can't perform the job that they had prior to that stroke. They have return to work coordinators that will work with these patients to either return to a different job, find them a new job. It's really a comprehensive program, and I wanted to mention that because it's all throughout the state of Kentucky. And on the CVent app, there are some handouts related to this Retain Kentucky program, also how you make a referral for your patients to the grant for them to receive this help if you think that would benefit your patients. This is just the case management workflow. So for the discharge clinic, we partnered with inpatient case management. They identify those patients that either do not have a PCP, they have an outside PCP, or they are high risk or have one of those 5 conditions. They will, through the discharge planning process, work with the providers to make sure that the right referrals get placed at discharge, and then that's how the patients get followed up into the discharge clinic. So again, just one of the process maps that we put into place as we implemented the discharge clinic. This is our patient brochure that we have just to explain all of the population health programs at UK Healthcare. And then lastly, which has been mentioned before, but this is such an important statement, that an organization will not improve without a clear and firm intention to do so. So through talking through all those population health programs and implementation, I sort of sounded like a broken record. These are the things you need to know. You need to set your aims, your measures, your change ideas. But once you get that hardwired into your brain of this is how improvement works, then you can just start plugging in change ideas and PDSAing all day long and making changes and improving your outcomes. And that's all I have. So thank you. And I will be around if you guys have questions, or if anybody has questions now, certainly let me know.
So, Jessica, we've got a couple online. So the first one is, does CCM have to be done by an RN? Can a CMA do this, or can it be is it reimbursable?
So CMS specifically says RN. Now, there are some clinics that do a hybrid of that, so they do have some outreach by either an LPN or an MA, but it has to be overseen by an RN, and the RN has to do the actual intake portion of that and the care planning portion. So ideally, you would just go with an RN, and then there's no confusion.
All right, so in our practice, PA develops the care plan. Medical assistants handle the day-to-day communication, but it's all overseen by the PA.
That's allowed, but any changes to the care plan has to be done by either an RN or the PA, yes.
Hey, Jessica, can you repeat the question if they ask?
Oh, yes.
So that you're not-
So the question was, does CCM have to be done by an RN? And then one person commented saying that they have a PA in their practice that creates that care plan, and then an MA does some of that outreach, and that is allowed as long as it's overseen by the PA, the RN, and that any changes to the care plan has to be done by an RN or higher.
All right, the next question we've got is, do the panel managers also look at patient acuity and risk level and work to balance how many high-risk patients the primary care providers see?
So we are working towards that. We, in our legacy system, had no way of being able to identify that in our patient populations, but since we've transitioned to Epic, we can now look at that. So yes, we have had lots of conversations around risk stratifying patient populations based on provider panels, so.
All right, and then we've just got one last one, and you talked about it a little bit with the financial barrier and resources overall, but how can you handle, and it just disappeared from me, but how can you handle addressing some of that financial barrier in initiating some of the CCM?
Financial barrier in initiating CCM.
Patient responsibility. Care cost. Oh, care cost.
So, patient responsibility for CCM is a copay. It's usually $5 to $8 a month. So that is a downside. I'm hoping as we move forward, CMS will decide to waive that. I don't know, but we do have patients that do not agree to enroll in the program just because of that $5 to $8 copay that's required. Yeah. All right, thank you.
Thank you, Jessica. And just real quick, I appreciate the speakers did a great job. I'm still thinking about how we're going to decorate our tree at home. And, you know, the big thing is Vance said we needed someone watching over us as we're doing our implementation. So I really need to decide, do I really want my wife or my kids doing that? I'm not sure which one's going to be easier on me while I'm decorating the tree. But yeah, I'll have to take a chance there. Real quickly, before we have a break, I want my staff to stand up so you all can see everyone that works at the Kentucky Regional Extension Center. If you have any questions, go ahead and stand all the way up. And then we have a table back there. But this is my staff, so if you have questions, anything about any of the presentations today or any of the services we provide, please talk to them, come talk to me. I promise we're friendly, so we want to work with you all too. So thank you all. Also, thank you, Mindy and team, for putting together this event and getting everything prepared so quickly. It's been great. Last, we're going to take a 15-minute break. Just a reminder, the exhibitors are back there, so go back there, see what they have to offer. The restrooms are this way for folks that came in late. I recommend going this way. There's a single restroom back that way. We'll take a 15-minute break, and then we'll come back and we'll introduce our next speaker. So thank you all.